probably be a different proportion of hybrid than it was before. Well, let's jump in. So I understand Shane's going to give a brief interview, kind of overview of the impact of sleep apnea on brain health, and then Stacy will introduce you, and then you can do your thing.
All right, thank you.
Welcome, Shane.
Thank you all. Thank you, Stacy. Everyone knows me, I hope. I'm board certified in psychiatry and sleep medicine as well, and I also work on sleep and sports psychiatry and integrative sleep stuff. So I'm really happy to have Stacy over here. I'll let her introduce herself. We're all about brain health and everything that impacts brain health, and sleep is a cornerstone of brain health, as we know. A study out of the University of Otago in New Zealand in December 2020 showed that when compared to exercise and nutrition, quality sleep was the most important factor for brain health. So of course, those things are also important, but we really need to drive down and see what the most effective strategies are for sleep. The cool thing about Stacy is that she's an integrative dentist and a sleep dentist as well. So it's not just everyone deserves a CPAP, like, you know, Oprah, everyone deserves a CPAP for sleep apnea. No, there's a lot of other great strategies to reduce the severity of sleep apnea. So she's going to talk about those things because it might mean lower pressures of CPAP even if you are using CPAP machines, thereby improving the quality of someone's sleep and reducing sleep fragmentation at night. So the goals of this talk are going to be to kind of go over how sleep apnea impacts every single one of the Bright Minds risk factors that impact brain health, how we can actually educate our patients about those things, and that helps with improving motivational interviewing piece and getting patients buy-in when we talk about sleep testing or sleep apnea treatments, and then specific tools that Stacy will discuss, and then options to refer people so that we know that there are people out there who are engaged in treatments beyond traditional CPAP. I'm going to share my screen now. I'm going to go over briefly the impact of sleep apnea on different risk factors for brain health. Let me just open this presentation here and I'll go right into it. So this is just a refresher for everybody, really. Sleep apnea impacts every risk factor for brain health. We are familiar with these SPECT images, and typically the imaging we see on people who have severe or moderate sleep apnea are the same kinds of patterns we see in traumatic brain injury. The frontal lobes are primarily affected, the temporal lobes are affected, and consequently symptoms do manifest. So the way I kind of explain it to my patients is, if you're going with sleep apnea every single night with severe or moderate sleep apnea, rather than basically getting a refreshing sleep that's restorative for your brain health, you're actually killing off brain cells every time that you're sleeping with untreated sleep apnea. So learning and memory, we know that the frontal lobes help you with processing speeds, concentration, sustained attention, executive functioning, multitasking, motivation, drive, social connectedness, pleasure, interest, suppressing impulses. And so the frontal lobes are affected. You're going to have slower processing, more procrastination, concentration difficulties, so on and so forth. Learning and memory, think about the temporal lobes, right? Which are also affected with sleep apnea. New learnings, memory consolidation, language, word finding, names. So in addition to the patterns looking identical to traumatic brain injury patients like my NFL patients, we also see that the same areas are also devastated in chronic alcohol use. So the same kind of patterns in chronic alcoholics will look like the same kinds of patterns in sleep apnea. Very important to remember. Retirement and aging is the other risk factor in the Bright Minds risk factors. The first is blood flow, temporal, frontal. Second is retirement and aging. It's quite clear, sleep apnea, which means a qualitative sleep issue, which also causes sleep fragmentation, is associated with all-cause mortality. It's directly related to the most common causes of death in this country. Heart attacks, drowsy driving, 6,400 drowsy driving accidents every year, strokes, cancer, dementia, all directly related to sleep apnea. Inflammation in the Bright Minds risk factors. We know that we have issues with sleep apnea through epigenetics actually affecting over 700 genes, 300 of which are upregulated, which worsen inflammation, and over 300 which are suppressed or downregulated, which are needed for immune modulation and reducing your cancer risk. Genetics, mentioned the epigenetics already. Head trauma, basically, if you are dealing with sleep apnea, same patterns as with head injuries, but also in the acne population, your reaction times reduce. Your risk of head injury increases because you can't see someone coming at you on the football field. And also, if you have sleep apnea that's undiagnosed or untreated after a head injury, it's going to delay your recovery or even prevent you from recovering fully. And the incidence of sleep apnea in those who have head injuries, it is bidirectional, increases dramatically. So in the average population, sleep apnea, depending on the studies, the prevalence is between 4 to 15%. Now more and more primary care docs are becoming aware of it and testing people, so that prevalence is bound to go up even more. But typically in a head injury patient, we find the actual prevalence of sleep apnea is more like 20 to 35 or 36% even, which is pretty large. Toxins, we know that this drainage system was discovered just a few years ago. The G lymphatic system helps flush out beta amyloid toxins and helps the microvasculature and nutrition go to the brain. The G lymphatic drainage system is only active in our sleep. So if your sleep is fragmented, if the quality is reduced through things like sleep apnea, beta amyloid can build up, and that is one of the possible pathways that's associated with sleep apnea and the dementia risk in the studies we've seen. M in the bright minds risk factors. Minds, M is for mental health. We know that sleep apnea is, again, bidirectionally related with depression, with anxiety, with mood instability, with ADHD, as well as substance abuse, because the frontal lobes, as we know, help suppress impulses. And if we're not having the frontal lobes taken care of, we might be more impulsive, resort to substances to deal with those issues. Also, psychiatric medications can cause weight gain and worsen sleep apnea. Benzodiazepines, opioids can worsen central sleep apnea and cause problems with your breathing while you're asleep. Definitely bidirectional. Emotional social interactions are affected with sleep apnea, again, picking up on social cues, the frontal lobes as well, and mood stability with the temporal lobes. Immunity and infections, even a small loss of sleep can impact your immune system. And they've actually done experiments with little cold virus droplets, those sadistic researchers, and they found that you were 3 times more likely to have symptoms of the common cold when you were getting less than 6 hours of sleep every night. And even with less than 4 to 6 hours of sleep a night, the next day your natural killer cells activity drops by 70%, makes you more vulnerable to cancers and viral infections. And also, comes to cancer, shift work, which is another sleep fragmentation issue, is directly associated with prostate, colon, breast cancer, and more research is underway for other kinds of cancers. And the bright minds risk factors, the neurohormones, we know that sleep apnea is responsible for lower testosterone levels, lower progesterone levels, early menopause in women, more cortisol, stress hormone levels with the HPA pathways, as well as more cortisol, more inflammation, more sleep fragmentation, worse sleep apnea, more weight gain. Diabetes, so sleep fragmentation, if you're losing out on 4 hours of quality sleep, your brain thinks you need 900 more calories. Leptin does not work properly and ghrelin is overactive. So children with short sleep duration, and again, I'm talking about sleep fragmentation. So if you're lying in bed with miserable sleep apnea for 9 hours a night, you might have had 2 hours of quality sleep. So children with short sleep duration, quality sleep, have an 89% increased likelihood of becoming obese. And again, obesity is the strongest risk factor for obstructive sleep apnea. Increased diabetes risk with sleep apnea, we know that as well. And it's pretty profound actually when they've looked at when you start someone at CPAP, use other strategies to help with sleep apnea, their symptoms actually reduce to prediabetes. You might have to reduce the insulin dose as well. So if one of your patients is put on CPAP and then they find that they're getting lightheaded, dizzy, or more anxious, they may not need more anxiety meds. It might be, in fact, that they need to lower their insulin levels because they're getting hypoglycemic. And that's something that I talk about in terms of sleep saboteurs from the bottom up. And that's something that Stacy is going to dive into, the integrative approach to sleep apnea and non-CPAP strategies as well. Thank you very much.
Thank you so much, Shane. And a lot of what you said, I mentioned a little bit, so I'll probably skip through some slides. I have a lot to say, so I'm going to do the best I can to make it as concise as possible. And like I have told Shane before, if you guys want to get more specific on certain topics that I kind of skimmed through, I'd be more than happy to come back if you ever would have me again and go over all that. So I'm going to share my screen. Can you guys see? Can everybody see my screen?
Yes.
Okay. So I wanted to talk a little bit about the collaboration between my profession and your profession, because I think a lot of what we're doing, we're trying to help the same population of people, but from a different angle, and we're going to accomplish more together by collaborating. So let me just fill you in a little bit about my background and why I'm a dentist doing this. So I'm a diplomate with the American Board of Dental Sleep Medicine. I've been serving on the dental task force for the AASM, which is the medical branch, trying to work on collaboration between sleep physicians and airway sleep dentists. I've been managing adult OSA for about 20 years now. I can't believe it, but it's been about 20 years with mandibular advancement, stabilization devices. Some people call it oral appliance therapy. And I got on this journey because my dad had apnea, obstructive sleep apnea, and was CPAP intolerant. And he really, 20 years ago was the reason for my start in this journey. I have 5 children that all have different levels of either OSA, upper airway resistance, or sleep-related breathing disorders. And as a mom, I needed answers and I wasn't getting it from the medical community. And as a disclaimer, I'm one of the co-founders of ASAP Pathway, which is Airway Sleep and Pediatric Pathway. So I'll go into my journey as far as going into pediatrics. So I had been working with my dad, who was CPAP intolerant, and all my adult patients. So 18 and older with advancement or stabilization devices to maintain a patent airway. And as I start having children, I'm noticing, okay, now they're mouth breathing, they're bedwetting, they're snoring, and I'm starting to see this, crystal ball of their future, of all the comorbidities that awaited them. And the medical community, aside from tonsils and adenoid removal, didn't have an answer for me. And so I started traveling a lot, trying to figure out what is the missing piece. And there are many missing pieces in the medical profession. And so my dad would say, why are you traveling so much? I never was able to breathe through my nose. I wet the bed till I was 12 years old. I was always tired as a kid in school. And I went back and I looked through my dad's pictures, and, my dad was mouth breathing, which you'll see this a lot with your sleep apnea patients. They don't just breathe poorly in their sleep. They breathe poorly all the time. It's exaggerated in their sleep. So you can see in these pictures, my dad had his mouth open in all of them, but that's just kind of how my dad's posture was. He always walked around with his mouth open. And, I was trying so hard to keep my kids from having this life of obesity, diabetes, neuropathy. He had a lot of health problems, I believe, as a result of poor sleep and that vicious cycle that Shane was talking about, with poor sleep, more eating, blood sugar off, gaining more weight. Now, guess what? More sleep apnea, poor sleep. So on Valentine's Day in 2017, I was getting ready to leave work and go to another sleep course for pediatrics. And we were texting all day in a group text about my dad's birthday Sunday. And he always loved, German chocolate cake and who's going to bring it. So we're group texting all day and my dad is in the group text, but he never responded to us. And my mom worked in the practice at the time. And I was getting on the plane and I could see my brother popping up at the phone constantly. And I just kept swiping, I'm buckling in the plane. I'm on the runway leaving St. Louis. We hadn't taken off yet. But when you get that feeling like, if I take this call, it's going to change my life. Like that overwhelming heaviness hit me. And I just slowly answered it. And he said, "Where are you?" And I said, "I'm on a plane. I haven't left yet, but I'm buckled in. We're going to leave soon." And he said, "I don't know how to say this to you, but Dad passed away today." And when you hear something like that, your brain can't wrap your mind around it. And I don't even know how I got off the plane. My assistant was with me, and I don't know, it's like I almost levitated and just got to the shuttle. I was able to see my dad's body before they took it away from my mom and dad's home. But he had passed, apparently, Valentine's night in his sleep. And, as a sleep dentist, my fear has always been, I know that people lose their lives over this. And so my fear was always that my dad would pass with my device in his mouth. Like that would be horrible for me. And he didn't have his device in that night. And he couldn't tolerate, his CPAP pressure was extremely high, and he couldn't even tolerate the combination therapy. So I went through a struggle when I lost my dad to sleep apnea, of almost like an anger towards adult sleep. I mean, I was very angry that I couldn't save his life. And I'm sure I gave him years of a quality of life that he couldn't have otherwise. But it really ignited my passion into sleep with children and how we can make a big impact other than just managing. What if we could get to kids and change the trajectory of their life? And while they're having all this brain development, which is so crucial by age 6, what if we could intervene early? And that's where I just dove in. I still manage adult sleep. I do. It's a passion of mine, but helping these kids and making a bigger impact in their lives is just almost like an obsession for me. I should say passion, but I guess it's an obsession too. This is my family. This was a few years ago, so the boys completely tower over me now. But I love this picture, but we by no means walk around like this all the time in my house at all. I am going to go over the anatomical aspects, and there's so much I want to say about both, and I'm going to do my best. I'm going to try to keep on time here, but there's the anatomical and there's the non-anatomical aspects of sleep. And this day was, it's a mom's worst nightmare. So I have one son in St. Louis with me having his tonsils and adenoids removed after I've done oral facial expansion on him for his obstructive sleep apnea. That was supposed to be the final piece. And that's 1 o'clock. And then my other son, who Dr. Creado, he's met, I brought him to the Amen clinics and very appreciative of what you guys have done. But he took a 1-day trip on a bus from St. Louis to New York, 24 hours. So basically sleep deprived, history of migraines. I've done everything, tonsils, adenoids, oral facial development, and I still couldn't get his sleep ideal. So he gets to New York, and I have his choir teacher calling me while my son's in the hospital that he basically fell to the ground in Times Square and had his first grand mal seizure, and hopefully, God willing, his last. But later I tested, within a month of this, I tested both of my sons, and one's vitamin D level was 26, the other was 22, and we all had disastrous vitamin D levels in our family. And I saw this meme, and it is the truth. A worried mother does better research than the FBI. And that's pretty much where my journey just took me. Was I wanted answers. And that's why ASAP Pathway was born. I'm one of the co-founders of Airway Sleep and Pediatrics, trying to collaborate with all of the within dentistry, within medicine, on how we can all work together, because we all have a piece of this puzzle together and we can help more people. So I'm going to start talking about the anatomical aspects first. So we can start off with habitual snoring. It can go to upper airway resistance syndrome, and it can go to full-blown obstructive sleep apnea. There are children walking around with obstructive sleep apnea that have not been diagnosed, but there's a lot of people, children and adults, walking around with habitual snoring or upper airway resistance syndrome. They haven't quite gotten to the obstructive sleep apnea yet, but they're walking around and nobody's identified those patients, and they have horrific sleep, horrific behavior, neurocognitive deficits. And there is a way that we can really help these patients. So one of the things that is outside of CPAP would be oral appliance therapy or mandibular advancement or stabilization devices. This is more for the population of 18 and older. So typically with CPAP, you are blowing air past the obstruction, past the soft palate and the tongue. With mandibular advancement or stabilization, sometimes I don't even have to advance the mandible very much. It's a stabilization of the mandible, similar to when you are giving CPR, you used to move that mandible forward so that the air can go in easier. In mild to moderate patients, this is considered equal to CPAP. In severe patients, that if they cannot tolerate CPAP, the Academy of Sleep Medicine says you should offer this to a patient. It definitely helps. It may not be 100% in a severe, or if you have a patient who has really high pressures, like Shane said, and they cannot tolerate, the 15 centimeters of water pressure. If we can stabilize the mandible and prevent that obstruction from happening, then you can drastically lower these pressures, maybe down to a 7, an 8, and make it much more comfortable for the patient. It also helps with bruxism. The Academy of Sleep Medicine has it in their standards of care that an oral appliance is considered equal with CPAP for the mild to moderate patient, and should be offered as an alternative to CPAP in the severe patient that is CPAP intolerant. And they prefer you, rather than no treatment whatsoever for snoring, they prefer you offer an oral appliance option as well. We know that there are sleep fragmentations from snoring, even though it's not necessarily obstructive sleep apnea. This is another management or treatment for sleep apnea in the adult patient. This is a surgical procedure called maxillomandibular advancement surgery. So if you look at the woman on her left, or our left, if you draw a line, this is Nasion. If you draw a line down, people should have their maxilla and mandible on this line or ahead of it. Not only is it more aesthetically pleasing, but what's most important is the airway that lives behind that face. So she grew what we call clockwise, which is down and back. And what we want humans to grow is down and forward. And as you can see, this is the resulting airway of someone that grows in a clockwise pattern, someone that mouth breathes, their jaw drops open, the maxilla, which is the floor of the nose, doesn't develop properly, and they have a smaller airway, and they have a threshold of a higher threshold of easier collapsible airway, basically. So if you look at the right side post-surgery, we can drastically change that threshold of collapsibility because we brought that maxilla forward and the mandible forward, and she no longer has apnea. So when you look at these kids, and even teenagers, we are treating an anatomical issue. There are definite non-anatomical aspects that I'll get into, but there are anatomical aspects that we need to recognize as physicians and dentists to intervene and say, this child is starting to have a growth and development pattern that doesn't look favorable to a healthy growth and development or outcome. And Dr. Christian Guilleminault, who is kind of like the father of sleep medicine, he said, once somebody walked up to him and said, "Oh, I have obstructive sleep apnea." And he said, "No, you had upper airway resistance syndrome at 2 years old, 4 years old, 6 years old, and just nobody helped you and you didn't get treatment. So now you have obstructive sleep apnea." So it's identifying that it is an anatomical issue. How do we intervene? How old is this person? What's the best therapy that we can provide so they don't have a life of having to live on a machine in their sleep at night? So if you look on all of these patients, this is a 9-year-old, small airway, 15-year-old, small airway, 37-year-old, small airway. And right now for this age group, we would do tonsils and adenoids and then CPAP. This age group, CPAP, maybe an oral appliance to manage it, maybe maxillomandibular advancement surgery. But what if we could get to this age group and we could intervene and change the growth and development non-surgically to prevent them from getting to this stage? So you can have a person that's occasionally snoring, going to regular snoring. What if we could intervene here before they get to the full-blown disease? So I'm going to talk more about the different ways that you can collaborate with dentists outside of just oral appliance therapy or maybe oral surgery for your adult patients. What if you could help your pediatric patients during that extremely important growth and development stage? So I showed you that woman a few minutes ago who was developing down and back. It's a clockwise growth pattern, and the airway is right behind it, and it's tissue paper thin. We did a surgery to advance her forward in a counterclockwise to make that airway larger and less collapsible. What if we could do this for children non-surgically? And it's most effective before puberty, but you also don't want to wait till they're 12 and 13 years old because of all the neurological developments that are happening at the younger age. So if you look in this little girl, this is my friend, Dr. Tracy Wynn's patient, sleep apnea. She was on a CPAP. They did protraction, which is the reverse pull face mask. She just put little rubber bands every night, would go to sleep. They did transverse expansion to expand the palate, which is the base of the nose. And you can see if you draw the line, her lower jaw is behind it. And then if you see here, her face is ahead of that line. And every millimeter makes a difference with a collapsible airway. So I'll briefly go over these. You guys know a lot of this already, so I don't want to waste a lot of your time. But we have GERD, asthma, ADD, morning headaches, excessive daytime sleepiness, nocturnal enuresis, bedwetting, which in adults that will be getting up to go to the bathroom frequently, periodic limb movements, and cardiovascular changes. Most of these are between adult and pediatric. And we see this relationship between GERD, asthma, ADD, and sleep disordered breathing over and over again. And we have an epidemic of children on all these different medications. We do know that the literature shows there is a link between acid reflux, GERD, and sleep disordered breathing. And it's kind of the chicken or the egg. We know that when we improve sleep disordered breathing and we change those thoracic pressures and we're not having that pull of the stomach contents through the esophageal sphincter, that we see improvements of acid reflux. But we also know when we improve acid reflux, we improve sleep disordered breathing as well. We also know asthma and GERD, same thing, a lot of inflammation in the airway. So if you improve that, you improve the asthma, you improve the asthma, you improve sleep disordered breathing. There's also a link between low vitamin D and all of these issues as well. And here's an example of a normal larynx in the trachea and an inflamed, injured larynx from acid attack. all the aspects of inattention and behavior problems that come along with ADD and poor sleep. This was a study done in Frontiers in Neurology. They were studying children with OSA and how it could lead to cognitive and behavioral dysfunctions. And basically, they were seeing that there were changes in cortical thickness in children with OSA, and both the thinning and the thickening associated with obstructive sleep apnea in kids contributed to cognitive and behavioral dysfunctions. This is Dr. Stephen Sheldon and Dr. David Gazal. They're pediatric sleep physicians. I've learned so much from both of them. Dr. Sheldon, he is a pediatric sleep physician out of Lurie Children's Hospital in Chicago. David Gazal just moved from Chicago to Missouri, so I'm glad to have him in my state now. But before we put children on medication, and I know I'm preaching to the choir here, we really should, there is such a correlation between ADD, ADHD, and poor sleep that they really should have a consultation with the sleep physician before we put them on any drugs or stimulants. And we used to have these names for ADD before we really even knew what it was. And it used to be called minimal brain damage. And they couldn't actually find the damage, so they renamed it to dysfunction. And now they call it disorder. But what Dr. Sheldon is hoping we can change it to is more of a syndrome and really sort out the cause of the syndrome and stop calling it a disorder. There was a study in 2017 in the Journal of Medicine that looked at the connection of obstructive sleep apnea and hypopneas, which isn't full-blown apnea, it's a flow limitation. They don't stop breathing fully, but they just have a limitation in the flow. And in that study, they looked at the ratio of boys to girls with OSA and hypopneas, and it was 2-to-1. Same boys to girls with ADHD, ADD, 2-to-1. And they noticed that ADHD occurrence correlated with an increase in allergic rhinitis and adenoid hypertrophy between the ages of 4 to 6. But in the age group of 6 to 11, all of those symptoms occurred with higher rates of enlarged tonsils. And then an increase in respiratory events as well as the hypoxia is correlated to also an increase in ADHD. So the take-home message is, when you find an obstruction in a child's breathing, it has to be removed as soon as possible to decrease the chance of that child developing neurological issues. I always talk about, you guys, when I speak, and we've got members all over the world now. So I'm hoping that you get more awareness for what you are doing, which is amazing, which is making the invisible visible, what we've all been searching for. And we knew that poor sleep was related to a lot of these issues. You guys are actually able to take the brain and see the emotional deficits, see the cognitive deficits, and actually see the sleep deprived brain itself. So I'm just so happy with everything that you guys are doing. It's changing lives. So morning headaches, if someone's waking up in the morning with a headache, you should wake up feeling refreshed. Restful sleep heals us. That's when growth hormone is only released during stage 3 sleep and when you're paralyzed. So children cannot grow unless they are paralyzed appropriately for the body to heal and grow. And adults cannot heal unless they're getting appropriate stage 3 sleep and paralyzed appropriately. The other thing that can cause morning headaches could be the hypoxias, it could be bruxing, it could be clenching, or a combination of all of it. Excessive daytime sleepiness. We've got kids all over the place where parents are buying them Red Bull, giving them lattes in the morning because they behave better at school. And you have to ask, why is a child who's already hyperactive with poor behavior, why are they functioning better on a methamphetamine, basically? Why are they functioning better on Red Bull, which is a stimulant? And what it's doing is it's stimulating the child to stay awake instead of the child acting out, talking, interrupting, fidgeting, and using behaviors to keep themselves awake. Nocturnal enuresis is a devastating thing, especially when kids enter older years past 6 and 7 years old. And there's primary and secondary, and there's many causes for secondary, but one of which is sleep fragmentation. It doesn't have to just be sleep apnea or upper airway resistance syndrome. It can be from fragmented sleep. We also see cardiovascular changes in children with OSA, hypertension, right and left ventricular dysfunction, cor pulmonale. We see this stuff with adults as well. Periodic limb movements, which is different than restless leg. Restless leg is when you're awake. Periodic limb movements, it's that, that crawly feeling, like when some people, they feel like they have to move their legs and they get really tired and they're trying to fall asleep. But once you go into sleep, it's then labeled periodic limb movement. And it can be very detrimental to sleep for adults and for children. Some of the signs in kids could be bedwetting as a sign that they might have an issue with PLMS. But sleepwalking and like leg pain in children is a sign as well. And iron is greatly linked to this sleep issue. And iron is essential for a lot of body functions, and including being a neurotransmitter synthesis, where iron is a cofactor with tyrosine hydroxylase, which then converts tyrosine to dopamine, which is definitely needed for control of those movements. But vitamin D, which really isn't a vitamin, it's a prohormone, but everybody knows it is a vitamin. Vitamin D can affect iron levels. And then those iron levels affect the dopamine levels and the transportation of the dopamine. And that affects periodic limb movements and sleep. So this is one of the non-anatomical aspects of, we are a deficient society. We're walking around with a lot of mineral deficiencies, and it affects us as humans. We like to see serum ferritin concentrations above 75, and we like to see the iron saturation around 20%. When it drops to 45 or 50, and all my patients that, I might get their apnea under control, but they're like, I still don't feel like I'm sleeping well. I mean, my airway is open, I'm breathing, I don't snore, but I'm still moving all over the place and I'm tired. And we have to check these blood levels and see if they might have an iron vitamin D deficiency, because they are related to each other. And as iron is increased in absorption, it increases vitamin D, which decreases hepcidin, which regulates iron. So if you change anything in this formula, it has an effect. You change D, it affects iron. You change iron and it affects D. There's an entire lecture on the prohormone D and all of the receptors in the brain. Heavily saturated vitamin D receptors in the brain, and the parts of the brain, throughout our whole body, but the parts of the brain that control paralysis in our sleep and control the sleep clock are different than when we're awake. And when when you have a deficiency in D, it's going to make sense that those organs and systems that have the D receptors are going to suffer. So the paralysis switch example would be if you're too paralyzed, that's an example of apnea. Not paralyzed enough is sleepwalking, sleep talking, chewing, bruxing in your sleep, periodic limb movements, fibromyalgia, people that have such chronic pain all over their bodies are not paralyzed in their sleep. They cannot repair, they cannot heal. The body cannot heal a moving body. It has to repair a paralyzed body. And then we have the sleep clock issue. So insomnias, advanced sleep phase issues, waking up at 3 every night, circadian rhythm disorders, REM sleep disorders, slow wave sleep issues. So what happens if we have low vitamin D and these aspects of the brain that are just intricately like a symphony controlling whether we're paralyzed just right or not paralyzed too much so we can breathe? What happens if they're malfunctioning? Then you have things like, I'm awake, but I'm dreaming. I'm awake, but I'm paralyzed. I'm awake and I'm falling to the ground paralyzed. I'm awake, I fall to the ground and I'm moving, which looks like a seizure, but where kinioplexy is different is there isn't amnesia like in a seizure. So if they remember, then it could be most likely kinioplexy or involuntary sleep attacks like narcolepsy. We also know that vitamin D is a bacterial growth factor, and it affects the microbiome and the endocannabinoid system. And there is a lot of traction with sleep, anxiety, and pain disorders and the endocannabinoid system. And there are studies that show that if your vitamin D levels are low, your gut microbiome cannot grow properly. And now you're not able to produce your own endocannabinoids that can control those things. We know that low D levels also lead to low magnesium levels. And I really have Shane to thank for better understanding the magnesium. It was a game changer in our family for sleep. And there's over 300 enzyme systems necessary that need magnesium. And magnesium and sleep are integral. Again, another non-anatomical aspect of the importance of maintaining proper sleep, that deep, slow wave sleep where we get the growth hormone, we get the repair, and it helps with RLS, PLMs, insomnia, migraines, ADD, ADHD, which pretty much is a lot of our patients. And Dr. Stasha Gomanek, she's the neurologist that really, I learned a lot from her with the role of the prohormone D and its role in every sleep disorder, not just sleep apnea, not just narcolepsies, but again, it's the paralysis and the timing switches, which every sleep disorder can fall under one of those two. It's either timing issues or it's a paralysis issue. And in the study, when they achieved 60 to 80 nanograms with their patients, they found that regardless of the sleep disorder, they had some type of improvement, which was really interesting because it's like you're not putting these sleep disorders in little boxes. They're really all connected somehow. So in the 1940s, and there's a whole lecture on this, you know, rickets and and vitamin D came out as like kind of a bone vitamin. And it's not a bone vitamin. I mean, it does help with calcium, but it is so important to pretty much every system in the human body. It's really a sun prohormone. So I want to go over just some signs and symptoms that you can identify when you're looking at your patients. And I'll go over these clinical signs and symptoms. I also gave you guys a pediatric questionnaire form. I'm sure you have your own. It's just something I give out. And then just something visually that you can look at to say, you know, this doesn't look right. So when you see a child with open mouth posture, and we all know Napoleon Dynamite with the mouth hanging open, it doesn't, I mean, that is mouth breathing and poor open mouth posture, and they are growing in the wrong direction. Their tongue is not in the floor, on the roof of the mouth, developing the floor of the nose, chronic chapped lips, no spacing in baby teeth, grinding their teeth, bruxism, enlarged tonsils, chronic ear infections, nightly snoring, tongue ties, labial ties or tethered tissues, crowded mixed or permanent dentition. They can't focus, they can't sit still, circles under their eyes. So this is an example of open mouth posture. These kids might have a dry mouth in the morning, chapped lips. They're constantly needing a drink of water in the morning, or they're licking or sucking on their lips. You might see this. This is a child that's most likely mouth breathing. And I always tell kids, you know, because a lot of times they don't realize they're supposed to breathe through their nose, and some of them never have. So they have something called nasal disuse. They've never used their nose. So I'll say, what is your nose for? And sometimes they don't really know because they've never used it. And when I ask, do you breathe through this or do you breathe through this? They'll tell me they breathe through this. And so I ask them, would you put an ice cream up your nose? And they laugh. And they're like, no, you put that in your mouth because your mouth's for eating. I said, that's right. Your mouth is for eating. Your nose is for breathing. And you're not supposed to breathe through your mouth. So the nose contains nitric oxide to kill viruses and bacteria. It humidifies the air. It warms, it purifies the air. The mouth does none of that. It also leads to oral facial growth issues, as I discussed earlier, if the tongue isn't in the roof of the mouth, and nose breathing. This is an example of clenching and bruxism when they've worn half their teeth down. This is like a 5-year-old child who's worn their teeth down, and most likely you can see acid erosion from acid reflux in this kiddo. You can see a lot in these kids. Sleep disordered breathing is categorized as a parasomnia in sleep medicine, so it is a definite sign of a child not sleeping well. Enlarged tonsils, these are class 4 kissing tonsils. And if a child has a hard time swallowing their food without taking a drink, or they gag easily, if you try to put something in their mouth and you're trying to look back in their throat and they gag, that's a they're very protective of their airway. It's usually because they have these giant masses of tissue blocking the esophagus and the trachea when they're trying to sleep. We take these images a lot as dentists. So this is a sagittal view. This is a child with growth and development issues. I can see his jaw is too far back, his airway is compromised, and here's a huge adenoid. It's like a grape blocking the nose. So when they try to breathe, they hit the speed bump, and it's easier for them just to drop the mouth open and start breathing through the wrong hole. But then that is a cascade of poor growth and development. One of my friends, her name is Dr. Audrey Yoon, just honored to know her. She's dual boarded with pediatric dentistry and orthodontics. And she just did a study with Stanley Liu out of Stanford, and they're releasing it soon. But just by pure expansion of the palate, which is the base of the nose, the floor of the nose, they saw a significant decrease in lymphoid tissues after the expansion. And she gave me a little sneak peek. Again, this hasn't been released yet. So there's a few sleep medicine and some other journals are wanting to post this in, but 36 out of 40 kids had a decrease in the adenoid size. 39 out of 40 had a decrease in the tonsil size. So these kids are breathing better, sleeping better just from expansion. Chronic ear infections, we've got the adenoids right by the eustachian tube. So if you have those swollen adenoids and they can't breathe through their nose, they might be a kiddo that's getting a lot of tubes in their ears and somebody's missing the fact that their adenoids could be enlarged. Nightly snoring is not acceptable ever. Snoring is not normal. It's not funny. This was a Karen Bonnick study that looked at children that snored at the ages of 4 and 7, and they all had behavioral outcome issues. And this is where the American Academy of Pediatrics then adopted the zero tolerance for snoring, and they now state that no child should snore, which I'm glad they've taken that stance. And a lot of parents don't know what their kids sound like, so I recommend something called Snore Lab. They can put it on their smartphones, they can record themselves, they can record their children, because sometimes they're just not convinced that their kiddo has a problem. But not all children with obstructive sleep apnea snore. So the other thing to look for is a lot of sweating in their sleep, bedwetting, really odd positions. If a child's head is hanging back or you see them in these weird positions, sheets all over the bed. Adults with sleep apnea will just lay there and just freaking die in their sleep. Children with sleep apnea compensate very differently. They will go into these positions where they're like, their high knees are in the air and their heads are turned and cocked funny. And no matter how many times you try to move them, the brain is like, my human isn't breathing. So it will go into any position it needs to. They compensate differently, much differently. So they may even have a sleep study and it comes back normal, but it's because maybe they're tilting their head, maybe their head's hanging off the bed, so they don't have any apneic events in their sleep study. So it's a little trickier with kids. This is an example of a tethered tissue. The tongue should be in the roof of the mouth, developing the upper arch. Nasal breathing should be happening. This is a tongue that is stuck and locked to the floor of the mouth. And an ankylosed tongue like this is more likely to fall back into an airway and not develop the face in the pattern that we would like it, that counterclockwise forward growth. So here is an example. When you're looking at kids, you want to see, when you see baby teeth, you want to see spaces where you could almost get a nickel between every tooth. that means that they have enough bone to support these big old teeth coming in. This looks aesthetically pleasing, but in baby teeth, this is already a malocclusion. This child already doesn't have enough bone development and isn't growing properly and will look like this within a few years. And it's not, again, it's not an aesthetics issue. It's, we need to ask, why does this kid not have this kind of spacing? And it's usually because they're not breathing properly through their nose. Their tongue is not in the roof of their mouth, developing the upper airway. So what looks really cute at 5 doesn't look good at 7. And it's really a sign that this child has some kind of growth and development issue. And you need to start asking some questions. How is their sleep? Do they breathe through their nose? Do they breathe through their mouth? Do we need to get them to an ENT, to a sleep physician, to an allergist? Already with this girl, there's no spacing with her baby teeth. And she shows a lot of gum tissue, which again is that down and back growth. Her face is growing down and back, and it's compromising the airway behind it. This is a video of my son, of just to show you how deficient his bone was. And the orthodontist in town was completely done with his treatment. He still had sleep apnea. And this is where I was trying to figure out why. And this is him at 15 years old. And he had the maxilla of a 4-year-old. Once I figured out, I learned under Mariana Evans in Philadelphia. But again, he was a mouth breathing child whose tongue wasn't in the roof of his mouth. But I'll show this quick video.
Going to be a video of the Anatomy model. I'm going to go through just different aspects of how Anatomy can help with creating basically a virtual model for you where you can import your CBCT file, your DICOM file, and then you can basically move the teeth around and upright them and make all the decompensation adjustments that you need to for the teeth. And then you can really kind of have a good idea of just really how much expansion you're going to need for that particular patient. Again, it's a guide. It's not set in stone, but it really does give you an idea. And I used this for my son, and it was pretty much pretty right on. So as you can see, we like to look at this view, anterior, posterior, a lot. From, looking from the behind the patient in a cone beam tells us a lot. And you can see as I'm slowly uprighting those lower teeth that are so tipped in from such a small amount of bone that's there. And as you upright the molars, you can see that you would be putting this kiddo in a crossbite. The other aspect of it is his upper molars were extremely tipped as well. And you also have to decompensate that tip. And then he's really in a crossbite. So look how much change he had to go through. When you put the teeth on their perfect access where they're supposed to be, you see just how much bone he was really compromised with. I mean, he didn't have enough bone for his teeth. So let's look at the same view. But now the bone is less opaque. You can also do this in an Anatomy. It's pretty amazing because you really can appreciate the long axis of those teeth a lot more than if you were just looking at even the prior view, which is pretty impressive. However, when you can see past the bone and actually look at those teeth, because really when you're looking kind of at the other view, it is impressive, but it's kind of no different than if you're looking at a stone model, really, because you can't really see the roots. So with this, you can really appreciate that everything's so, it's just compensating. And look at how that nasal cavity changes. We know that there's some studies out there that show when the palate is increased by about 1 millimeter with expansion, for every millimeter, you get about 2.4% in increase in the nasal volume. So you can appreciate the ability for him to breathe better even.
So with my son, he needed 10 millimeters of expansion. And that is about a 30% increase in his nasal volume. I don't know why my thing is going forward here. I'm going to back up a little bit. Here we go. So again, another sign, ADD, ADHD, venous pulling under the eyes. And you see these dark circles under the eyes, poor circulation, unable to flush out the blood supply underneath the eyes is a sign of a constricted maxilla, allergies, issues with breathing. And something that, you know, I'm sure we all look at is, what does someone's eyes look like? Like Shane was saying earlier, the faces of people with behavior disorders, it is a real thing. And when you can see the sclera underneath the iris, that is not normal. That is a sign that this child's midface is not developing past that nasation line. It's flat. And so you're going to see the sclera. And if you look at a lot of these kids that have behavior disorders, are sitting in the principal's offices all the time, active shooters, they have a look. Witnessed apneas, you know, nobody should not be breathing in their sleep. This is a drug endoscopy, drug-induced sleep endoscopy, and it shows the collapse basically of a child with sleep apnea. And the parents wanted the child off of a CPAP. And so this is my, my partner Tracy's pediatric patient, and they're trying to figure out how far that jaw needed to come forward until it didn't collapse anymore. So using this drug-induced sleep endoscopy, they were able to know how much further they needed to get the face forward. Shane, how am I on time?
Yeah, we're gonna have to stop now. Unfortunately, it only goes till 1:30 Pacific time. So this has been awesome, though. I really appreciate both you and Shane's contributions to this. It's been very good. Are you there? Yeah, I think we timed out the Zoom.
Well, thank you. I'm see things differently.
Well, thanks so much, guys. Good to be with you, everybody, today. Have a great week.
Thank you
Stacy,
so
thanks
much.
again. Appreciate it.
Thank you so much.